Thank you for joining us. We'll be discussing today such an important topic, medication safety, protecting your patients and your practice. We want to make sure that you have these key takeaways after we conclude our discussion. First, gain a greater awareness of the issues driving medication-related mortality and morbidity. Learn about changes you can make to improve your day-to-day practice and support safe and reliable care. Explore medication technologies and their related benefits and limitations. Understand the nurse's role in addressing system opportunities for improvement, and take advantage of ongoing learning to optimize patient-centered outcomes.
I think it's important to differentiate between knowledge and assumptions. Knowledge, and we've always heard knowledge is power, but knowledge is defined as facts, information, awareness, and skills that are acquired by a person through experience, education, and study. It's the theoretical or practical understanding of a subject, such as the indication for a specific drug. Knowledge is scientifically proven. And as a vital member of the healthcare team, nurses should maintain a thirst for knowledge. Science is dynamic and always changing, particularly in the drug world. Assumption, on the other hand, is the act of taking possession of something. It is assuming of power or responsibility, believing something to be true without scientific proof. An example is an assumption that glucosamine chondroitin is an effective supplement to reduce osteoarthritic joint pain. It has not been approved by the FDA, meaning that there's been no scientific data to support its efficacy, safety, or indication. In 2022, the FDA approved 37 novel drugs after an average of 51 new drug approvals every year since 2017. So there was a decrease this past year. There are over 19,000 prescription drug products approved by the FDA for marketing in the United States. I think it's important to understand and appreciate the science that brings a drug to market. A drug begins as a molecule and takes between 10 to 15 years for development. It requires billions of dollars before use at the bedside. There are 4 phases in the development of a drug in order for it to be prescribed. Phase 1 is the discovery and development phase. Phase 2 is the preclinical phase, and that's when doses are determined, metabolism, excretion. These are usually small studies. And then the third phase are the large randomized double-blind placebo-controlled trials, which is the highest level of evidence. It reduces bias and by having arms blinded. And then the fourth phase is when the FDA approves medication for the marketplace. The FDA defines a drug as intended for use in the diagnosis, cure, mitigation, treatment, or prevention of disease. The FDA indication for a drug is what a drug should be used for. If medications are used off-label, those are medications that are not approved by the FDA. For an example, I see a lot of Elavil or amitriptyline used for migraines, but it's not, the FDA has not approved that medication for that indication. So if someone is going to be using off-label medication, they need to have at least 2 peer-reviewed studies to support them in any professional risk situation. So where do you go to find the evidence? We just talked about the package insert, but also understanding that randomized double-blind placebo-controlled trials are what are the key and standard of care, gold standard of care in bringing a drug to market. Systematic reviews are a combination of randomized controlled trials, and then the evidence-based guidelines are a combination of randomized controlled trials and systematic reviews, and usually written with a panel of experts, clinical experts, which also include nurses. The FDA black box is also an important thing to understand. Let's go back to NSAIDs again. There is a black box warning by the FDA for anti-inflammatory drugs because of the risk of thrombotic events in combination with other medications. It can also precipitate myocardial infarction and stroke, which can be fatal. So when I'm prescribing an anti-inflammatory, and in the orthopedic world, I always make sure that patients don't have underlying cardiac issues when I'm considering that medication. So from a liability perspective, it's important to understand where to find the evidence. I love Hippocrates. If you haven't downloaded a free app on your phone, it's a good opportunity to find out dosages of drugs and drug-drug interactions. We did talk about the package insert that also provides that information. Documentation is very important. So you'll want to make sure that you always provide detailed information about the drug, the dose, the route, the time, and any adverse events that may happen with that drug, and document any adverse events and what actions that you took. I think it's important for nurses to always question drug-drug interactions. If somebody writes an order that doesn't seem right, to question that. If the dose doesn't seem right, or the combination of medications don't seem right, discuss that with the prescriber. As nurses, it is our responsibility to question orders that are unclear, unfamiliar. If it is unfamiliar, look it up. I'm not comfortable giving or prescribing a medication that I'm not familiar with without reading some of the original studies that brought that medication to market. So the more information we know, the more we will protect our practice.
How can we shift our focus to ensure not that we're ignoring our professional responsibilities as nurses and focusing purely on reacting to error, but thinking about how we can prevent error in the first place? And it's my hope that you leave here with one concrete thing that you can do or think about differently after this session is over today. But earlier this year, a study came to our attention by Dr. David Bates and colleagues who were examining the frequency and types of harm in random hospital admissions across 11 hospitals in my home state of Massachusetts. And this was from 2018 data. So the context for what I'm sharing with you is pre-pandemic. Over the 2,800 admissions that they reviewed, at least one adverse event was found in every 4 admissions, and many of those patients had more than one adverse event during their stay. A third of the admissions had a severity level of serious or higher. 23% were deemed preventable, and patients who had an adverse event had a length of stay that was nearly twice as long as those who did not. As you can see on the right-hand side of this slide, a majority of the events were associated with medications, and other studies that have examined the frequency and types of harm also find that medication-related adverse events top the list of reported harms. Administration of drugs that were not ordered and wrong dose administrations. So this data reinforces that workarounds are associated with med administration errors, even when the technology that's available to prevent those errors is available, and suggests that it's really important for us to not believe that just because we've implemented technology that we are effectively safe. There's a lot to think about here, particularly in understanding how humans are interfacing with the technology and sometimes the over-reliance on technology. So in healthcare, what we're aiming to do for failure-free operation is to support the delivery of safe, timely, effective, efficient, equitable, and patient-centered care. And the quest for safe and reliable care really requires our organizations and everyone who works in it to embrace and embody the vision, goals, and core values to eliminate harm, to prevent harm from occurring in the first place, and not just to say this on a website or on a piece of paper, but to encode this in our daily work. And this requires, as many of you know, leaders who are setting the tone for and stewarding and holding themselves and others accountable for eliminating harm. And cultures of an organization matter very, very deeply. But I thought what I would share on the right-hand side of this slide is an image that I credit to my board chair, Dr. Jerry Hickson, that reminds us that safety is a system property. And it's a product of both intentionally designed systems and professional accountability at all levels. And it's a constant balancing act. So I would invite you to reflect on the question, can we say that we are safe in our organizations, in our daily practice? And I would propose that we are only as safe as the moment that we are in, and as safe as we are proactively designing our systems to be safe and our professional accountability, again, on that moment by moment basis. And if we just reflect for a moment on what happens in our workplaces when something goes wrong and some of the common considerations that come up, one of the very first questions that we hear repeatedly in our work is that folks ask, who did it? Often followed by, how could they have done it? And passing judgment on humans for their failures. Now, another person who's really examined this phenomenon and what it means for healthcare and our ability to be able to make progress in safety is Amy Edmondson, who's an emeritus member of our Lucian Leib Institute and a world-renowned organizational behaviorist and expert who's really credited with expanding what we know and understand about psychological safety, which is the belief that one won't be punished or humiliated for speaking up with ideas, questions, concerns, or mistakes. And in teams, which is what we all work in, and typically interprofessional, it refers to team members believing that they can take risk without being shamed by other team members. So the knowledge that one will be treated with respect when one does voice a concern and that the organization will act on concerns is essential for safe care. But what we know from our studies of patient safety culture is that this is consistently one of the lowest scoring domains found across all healthcare settings. And to Dr. Leip's point, this can really inhibit the very actions and behaviors that are necessary for safe and reliable care and for learning to continuously improve the safety and reliability of care. There can be undue burden placed on humans for the full responsibility for safe care, and sometimes little reflection on the importance of the intentional design of systems. And this publication goes on to state that failure to follow the 5 rights perpetuates the mistaken belief that healthcare practitioners can be held individually accountable for achieving these goals, and that none of the rights, in fact, provide procedural guidance to describe how to accomplish the desired outcome in a particular environment of care. Now, I want to make it very, very clear that this is not to suggest that the 5 rights are unimportant and they shouldn't be used. What we're trying to convey is that we have humans who are working in a very highly complex, safety critical, and socio-technical system that is the healthcare industry. So reliance on human operators and our vigilance as the primary and sometimes sole strategy is really quite brittle and inconsistent with what we know is necessary for safety.
Thank you for watching this webinar preview. My name is Julie Cullen, the managing editor of American Nurse Journal. I invite you to watch the full version of this free on-demand webinar. Just follow the link in the description. You can also visit myamericannurse.com for a full collection of our free educational webinars. Thank you.